Now moving on to our second section, that is the metacarpophalangeal dislocations. As you know, that the carpal bones are attached to the metacarpals, and that these metacarpal are attached to the phalanx. And the joint between the metacarpal and the phalanx is called as metacarpophalangeal joint. In this section, we will be discussing a simple dislocation and then the complex dislocation, which is sometimes associated with fracture or the palmar plate rupture, and we'll be briefly discussing the metacarpophalangeal joint dislocation associated with chronic instability as well, in which the palmar plate ruptures and there is a chronic instability and insufficiency of these ligaments. So what is metacarpophalangeal dislocation? It is an entire digit is suddenly forced into hyperextension, and the capsule and the muscle insertions in front of the joint may be torn, that is on the palmar side. Usually the thumb is always the most affected part, as it is most mobile in the hand. Sometimes the fifth finger, rarely other fingers are involved, but they can be involved at times as well. Now, types of dislocation, briefly they can be divided into two types, the simple one and the complex one. Simple one is simple dislocation associated with trauma, and there is always ligamentous rupture but no fracture. In complex dislocation, what happens is there is associated fractures as well, and sometimes these fractures can cause, along with the palmar plate rupture, this can lead to bony blocks, or palmar plate can get stuck into this fracture segment, in which therefore reduction is actually hampered. This is called as complex dislocations. If you see this diagram, this is this X-ray of a hand, and if you can appreciate over here, the fifth finger, this is the metacarpal, this is the phalanx. The metacarpophalangeal joint dislocation is actually can be seen over here, and this looks like more towards the extensor surface, and classically injury of presentation would be that the finger has gone into excessive hyperextension, leading to rupture of these areas of the palmar ligaments and leading to dislocation. Although true AP view may be normal, but if you take the oblique view as well as the lateral view, sometimes you can get the idea whether how much dislocation is actually present as well. Therefore, it's important to get AP, lateral as well as sometimes oblique view as well, to get the idea of 3D idea of the dislocation. How do we take the idea? The best is to extend the digit at 75 degrees, as you can appreciate it over here. And this kind of oblique view will clearly demonstrate whether there is dislocation or not. And how do we reduce it? The reduction maneuver is always, but first with a close reduction. Under complete analgesia or under sedation, the patient is actually the hand is held by the one hand of the surgeon, and the traction is actually applied by the other either assistant or by the surgeon's other hand. So the traction, once the traction is there, then it can be first it can be hyperextended. This hyperextension can then be flexed and leads to reduction of this. Why this is hyperextended? Whenever we are doing the close reduction, first we have to increase the dislocation, and then with the traction re-dislocate the joint back into the position. As I told you, first there's traction, then hyperextension, then pulling the finger around, leading to the flexion of the finger and reduction of the joint. And once the joint is reduced, finger is strapped towards neighbor finger, that is called as buddy taping can be done, and initially the other joints can be easily moved at this. Only the carpometacarpal joint is actually normal. This can be, movements can be done over here as well. The proximal interphalangeal joint, distal interphalangeal joints are normal, so there can be range of motion can be started as early as possible. But only in the metacarpals and phalangeal joints, as this has dislocated, this is actually kept movement. There is no movement for at least 4 to 6 weeks. And for other joints, early mobilization can be encouraged. Now, if you see this diagram, this is also a reduced dislocation, but it's usually associated with a bone fleck, which can be seen over here as well. Now, this means there was even small part has actually fractured. And this is why it is called as complex, because there is an avulse palmar plate which sits in the joint, which is blocking the reduction at times. Or even if the reduction is possible, it's not completely reducible, and this remains subluxed, and later on it can redislocate. So metacarpal head can be clasped between the flexor tendon and lumbrical tendon, and as a result, these tendon can get engaged in between them, and then can cause the failure of the reduction. So it's important the digit has to be extended about 30 degrees, And this is where at this point we can get the maximum x-rays, whether on lateral view at this point we will be able to know whether there is a palmar plate or impaction is there in the joint or not, or the joint is completely reduced or is still somewhat subluxed. Then important point is on examination is always tell little dimple in the palm, which can actually tell whether the palmar plate is injured or not, or it is actually retracted back into the joint or not. And how do we reduce it? Well, very occasionally we have to reduce it by hyperextension the metacarpophalangeal joint. Otherwise, most commonly any joint carpometacarpophalangeal dislocation, whether it's simple or complex, the first and foremost maneuver is always the attempting of close reduction. If easily close reduction is possible and joint is completely reduced, well and good. If it's not, then we may have to open the joint and disengage the palmar plate out of the joint, and so that we can reduce back and using the K-wires to stabilize the joint. Rarely it's resulted in a hyperextension of the metacarpophalangeal joint of the thumb mainly. This is so what to do with that is flexing the interphalangeal joints usually release the clasp over the metacarpophalangeal joint of the thumb dislocation, and we can reduce it back and apply thumb spica in this position as well. If it fails, then we have to go for open reduction and ulnar fixation. And what is the procedure? We have to usually go for open reduction, remove the volar plate out of the joint, and then once the joint is reduced, we apply K-wire so that the joint remains in place. Usually dorsal approach is the safest, but we can go with the volar as well as the dorsal approach. Now coming to the chronic instability in the thumb metacarpophalangeal joint. What happens is if there's damaged ligaments, this can lead to subluxation and chronic instability of the thumb. And this could be very problematic because the pinch movement of the thumb is actually based on these ligamentous restraints, so that the metacarpophalangeal joint remains stable. Once this does not remain stable, this pinch effect is actually affected. This is usually treated by sesamoid orthodesis. Sometimes there are two sesamoid bones which are found in the metacarpophalangeal joint of the thumb. There is an abductor side, and one is on the adductor side. Usually the abductor sesamoid is fused to underside of the metacarpal neck, and it is actually alternately we can simply remove the articular surface and fuse the metacarpal with the first phalanx, leading to traditional form of orthodesis by using K-wires. And the treatment of the chronic instability is actually most of the time is always orthodesis. Why? Because over the chronic period of time the ligamentous reconstruction is not easily possible, and even despite the ligamentous reconstruction done, it does not have a very high success rate. Therefore, the best method is to so that the pain and the movement all can be settled by use of orthodesis. And low profile compression plates actually allow early mobilization, but most of the time K-wire is more than enough for orthodesis. Even low profile plating can be done as well. In this section, we have briefly gone through the metacarpophalangeal joint dislocation. The most commonly involved is the thumb area, and rarely the fifth finger is involved as well. And usually, whenever it's a metacarpophalangeal joint dislocation, it could be simple or complex. The best way is to reduce is by closed means. Close reduction is always attempted under anesthesia, and then once if it is reduced properly, this can be post reduction. The joint can be held in immobilization by simple putty taping. But if it's not getting reduced, this is usually due to the palmar plate injury and it gets stuck into the joint. Therefore, open reduction has to be done, and palmar plate has to be removed. The joint has to be reduced, and K-wires has to be passed so that the joint can remain in place. Thank you very much. Keep watching sqadia.com.